So hi everybody, and welcome to Hope for Migraine CGRP group and also to migraine.com. So we are co-hosting today, and I'm very excited to introduce to you Dr. Robert Cowan, who is the director of the Stanford Headache Center, and he is going to be talking to us about the 4 new migraine medications which we expect to be available over the next few months. So Dr. Cowan, why don't you tell us a little bit about yourself?
Sure. So I'm a neurologist by training. Board certified in neurology, psychiatry, pain medicine, and headache medicine. I've been a specialist for about 30 years. I've been a migraine sufferer for more like 60 years.
Wow.
And we have a big program, an active program, a lot of research going on, a lot of clinical care going on. And I don't know what else to say.
That sounds good. It's a great start. So I wanted to, first of all, just get a quick overview of the next 4 medications. So the past year has been really exciting. It's really been a new frontier in the treatment of migraine with the CGRP monoclonal injectables, Aimovig, Jovian, and Emgality, but there is more coming out, and so that is really exciting for us. And my understanding is that we have the first of the dietins, which is Rayvow, then we have ubrogepant, we have rimegepant, and eptinezumab. So maybe you could just tell us real quickly about those 4 medications.
Sure, I'm just impressed you remember all those names.
Yeah, I've been practicing the pronunciation.
That's excellent. So it's true, the monoclonal antibodies, the first of those came out about 18 months ago. And now we have 2 additional antibodies and a 4th one coming out sometime next year. In addition to the monoclonal antibodies against CGRP, right, there are also CGRP antagonists. And I think it's a mistake to confuse the 2 different classes because they're significantly different. But there are 3.
So they're saying, can you put the mic closer to you so that you can be heard
so you
better?
Can't hear very well, we've been told, so we're just going to move everything a little bit closer.
So now we're larger than life.
Yes, exactly.
I was just saying that the monoclonal antibodies are one new class of drugs which are being used as preventives for migraine, but another class which are also CGRP related, but they're antagonists to the molecule. In other words, they compete with CGRP for the receptor, will be coming out next year, and they will be also migraine preventive in all likelihood, but they will also be for acute treatment. Okay. So I think it's important to understand that there are 2 distinct groups. You also mentioned the DITANs, right, and the first of those has been FDA approved, but there are still some issues as to what kind of black box warning.
Right.
So we'll have to see how that develops. Those are not yet available. We don't really know what the impact of FDA decisions will be on those.
Okay. Actually, since you brought that up, let's go straight to that question with Rayvow and the additional review, which we don't always see with all medications after FDA approval. So can you explain to us a little bit about why it's going through that additional review?
Sure. So the reason for the additional review has to do with questions about the impact of this medication on driving. So this is being looked at more carefully. There will be a warning about driving on these medications, and some efforts are being made now to determine what that warning will look like and what patients need to know about driving on DITANs. Right. In addition to the questions about driving when you have a migraine. Which,
which is an issue in itself.
Should be concerning for a lot of people as well.
Definitely. Okay. So skipping straight to the next monoclonal antibody, which is eptinezumab. I don't know if we have a brand name for that yet, but I know that that is going to be administered through IV as opposed to self-injectable. How do you, what is your understanding of how that is different to the current 3 injectables that we have out? And if someone, for example, has failed 2 or 3 of the injectables, is it worth their while trying eptinezumab through IV?
Okay. 3 questions in one.
That was a lot of questions, okay. Yes.
Okay. Well, I think it's important to remember that the 3 that are out are not identical.
Right.
The first one is the Amgen product, came out as a monoclonal antibody to the receptor. That means that the antibody latches on to, if you think of it as a lock and key mechanism, it latches onto the lock and hangs up the lock. The other 2 that came out, the Lilly product and the Teva product, are actually antibodies against the the molecule itself, the CGRP molecule, what we call the ligand. And the reason that's important is because the ligand, the CGRP molecule, has a half-life of about 7.5 minutes. If you're not familiar with a half-life, that's how long it takes the body to burn up or eat up half the molecule. So if something's got a half-life of 7.5 minutes, that means after 15 minutes, half of it's gone. Right? And then 25%, 12% on down. So you've got a molecule that's got a half-life of 7.5 minutes. You've got an antibody that's got a half-life of, depending on which one you're talking about, between 28 and 42 days.
Right.
And then you've got a receptor that's got a half-life of about 3 months.
Okay.
So the kinetics gets very, very complicated as to how long these things are active in the body. I know this is complicated, but it actually is important. It actually is important. The antagonists that are coming out, they have a half-life, depending on which one you're talking about, but in the neighborhood of 10 to 12 hours. So that means if a CGRP molecule attaches, if you think of the CGRP molecule as being a key, if that fits into the receptor or the lock, it's active for about 7.5 minutes before it starts to get broken down by a process called proteolysis. If you have the molecule itself, it's 7.5 minutes, but if you have the antagonist, the new product, it's got a half-life of 10 or 12 hours. So it changes the kinetics of when that receptor becomes available to interact with another CGRP molecule. So these are really not all the same, even when you're talking within the MABs or within the antagonists.
Yeah, that's interesting. You know, is there a general sense among doctors that with these next 4 medications that they don't really bring that much new to the field of migraine treatment, or is there a lot of excitement at the possibilities of them, or is it mixed?
Yes.
Mixed, okay.
Yeah, it's very mixed. It's clear this is the first new class of drugs for prevention of migraine, and that's a big deal. It's happening because there's an increasing awareness that we as migraine sufferers matter, and we have money in our pocket, which is the big motivator for pharma. And so it is a big deal that we're getting new classes of drugs. The flip side of that is they're coming to market without a whole lot of information. So there's still a lot we don't know about CGRP, or we don't know about why CGRP is everywhere in the body, if it's okay to block it. So there's a lot of questions that persist. But I think that having new classes of drugs, I mean, it's always good to have more tools in your bag. I think how you use them is very important. You know, you can use a hammer to nail, or you can use a hammer to break glass. We prefer the nail to the glass.
That's always preferable, definitely. So you said that there's still a lot of unknowns about them. They're coming to market without an awful lot being known compared to maybe some other medications in the past. So have there been studies done on, for example, people who have chronic migraine as opposed to episodic migraine? And have there been studies done on people with comorbid conditions, people who would generally be excluded from the early trials, like fibromyalgia?
It's a complicated question, to be sure, but I think it's probably the most important question to ask. If we can take a step back and think about what CGRP does in the body. So CGRP is in virtually every organ system in the body. It's in your brain, it's in your gut, it's in your lungs, it's in your kidneys, it's in your liver, it's everywhere. So obviously it's doing something. I mean, the way evolution works is stuff we don't need tends to fall away. All indications are that CGRP is what we call a stress molecule. It's important when the body's in trouble. For example, CGRP levels go sky high when you get hit in the head with a baseball bat. Unfortunately, we're not allowed to do studies in which we hit people on the head with a baseball bat, so we don't know the consequences of that. We are not allowed to induce strokes in human beings, or heart attacks, or to cause irritable bowel syndrome. So we don't have information about what happens in these populations. The only studies we're allowed to do are studies on otherwise healthy individuals. So what we know for certain with the monoclonal antibodies is in people who are healthy, except for having migraines, who have no active comorbidities, like unstable heart disease or active irritable bowel syndrome or things like that. We know that it's been shown to be safe in about, now we're up to somewhere just above 500,000 people who have used these. We've had some signal. As you know, the Amgen product now has a warning for people with GI issues.
Okay, interesting. I didn't know that they already had that warning out.
Which was not present when the drug first came out.
Right.
So little by little, as the numbers get bigger, you start to see subpopulations. For example, we can't do a study practically on people who take the antibody and then have a stroke. But eventually we'll have enough people so that some of the people on the antibody will have had a stroke. But that's going to take millions of people.
And many years.
And many years.
Right.
A good example is the medication Vioxx, which was an anti-inflammatory that came out a number of years ago. We didn't know that it had dangerous consequences for a subpopulation until there were over 100 million prescriptions written.
Okay, that's a lot.
That's a lot. And so while it's comforting to know that there's 500,000 people who've been on the antibody without any horrific event, we just have to be mindful that the numbers are not there yet.
Right, that makes sense. So I know this is one of the questions I had at the end of my list, but I want to ask you it quickly before we go back to the new medications. And that is, I know that some doctors have seen some side effect trends, and we have seen some trends in my group, Hope for Migraine. Some of them, there really aren't a lot of trends, but some there really are, like the GI issues, hair loss that we're seeing. Is there a general time frame for the pharmaceutical companies to update the medication guides, or does that really vary? And how important is it for patients to self-report to the pharmaceutical companies and to the FDA?
So let me start by asking you a question.
I don't think that's the way it works here, but okay.
It's not a trick question. Do you know what the greatest motivator for a patient to try a new medication is?
My guess would be that other things are not working, or that they are having intolerable side effects, or they have contraindication to it.
No.
Or all three. It's not.
No.
Okay.
It's the recommendation from a friend.
Interesting. Okay.
More than hearing it from the doctor,
Right.
more than the scientific literature, more than the direct-to-consumer advertising.
Okay.
It's whether somebody said it was cool,
Right.
right? Belief is always more powerful than data.
Mm-hmm.
So what that means in terms of the risks and red flags to keep in mind is anecdotes are useful, and that's where everything starts. I mean, I always want to hear from my patients how they're doing, but that's the doctor in me taking care of one patient. The scientist in me reminds myself, have these inner conversations.
Right.
I hope that's okay.
No.
Reminds me
Absolutely.
that anecdote is not
Right.
enough. You need data. Unfortunately, as we just said, getting data can take years and years and
Right.
years. So we watch for signal. We watch for things. We talk to each other. We have these listservs of specialists, just like you have
Right.
your collection, we have our collection,
Mhm.
and we see things and we watch for things. We think about, well, okay, somebody was just hit by a meteor and they started their antibody.
Right.
No, probably not related.
Probably not.
But if we have 50 people say, my IBS or my rheumatoid arthritis got so much worse, even though my headaches got better, we start to think about, well, is there a reason that could be? What kind of a study can we do?
Right.
So that's sort of the process that good doctors go through when you start a new medication.
So it's important, in other words, for someone who's trying a new medication, not just to share it online or with their friends, but to make sure you tell your doctor. Not all doctors write down, not all doctors are great, unfortunately, a lot are, but not all are. So to report it to the pharmaceutical company, to report it to the FDA, so that we have this overall amassing of information. So just want to just affirm that everybody out there, if you are taking one of the new medications and you think you may be having a side effect, please report it, because that helps us come up with more scientific evidence or an idea of what they may or may not be doing. Would that be right?
That's
Okay.
exactly right.
Perfect. So here's a really hot question. And you may not know the answer to it, but can the new Gepants, rimegepant, ubrogepant, be used in conjunction with one of the injectables?
So we don't know the answer.
Right.
We can look at it from a theoretical standpoint. From my perspective, it probably wouldn't be a good idea. And I think the reason I say that, I know the reason I say it, but I don't know that it's true,
Right.
because we don't have any data.
Right.
But I'm working from the assumption that CGRP is important in the body for some, for some function.
Right.
If we're blocking the receptor and we've got antagonists and we've got monoclonal antibodies, we're basically, with each additional mechanism of blocking more and more CGRP, I worry about that because I don't think we yet know the consequences. None of the monoclonal antibodies block 100%. They get up to 80, 85%. You put a antagonist on top of that, and you probably are getting close. And what if you do get hit in the head with a baseball bat,
Right.
Or you have a stroke,
Right.
or an ulcer?
Right. We don't know what will happen.
So I, as a clinician, will be very reluctant to do that.
Okay, that makes sense. So coming at it from the other side, if for someone for whom the injectables have failed and they're really not successful, is there any chance at all that the Gepants may be successful as an abortive, or really not? Is it worth trying?
As far as we know, given how lovely, if I can use that word, the side effect profile is for the Gepants,
Yeah.
I think it's very reasonable to try it, but you want to give enough time between the two for there to be a washout.
Okay, and that would be, are you talking about 5 half-lives or less than that?
It's really
Hot
complicated.
question.
As I said, if you've got a monoclonal antibody with a half-life of 28 days and an active ligand with a half-life of 7.5 minutes, how long is it?
Right.
I mean, what's the half-life of the combination?
Right.
And then Japan's, at 10 hours. I think it's reasonable to wait, maybe not a full 5 half-lives because it needs to graduate, but I would definitely have a washout period of a month, 2 months,
Okay.
3 months. I don't know what the right number
Right.
is.
I guess we'll figure that out.
And it would depend a lot on the situation of the patient. I mean, I have patients who say, I understand everything you're saying. I understand all the things you've told me we don't know about this,
Right.
but I am so desperate I'm willing to take the risk. Well, it's not my job to, I'm not their mother,
Right.
And if I feel they've had the information and they make the decision they want to try it, I'm not going to stop them.
Right. Interesting. Okay. So still a lot of questions that we just really don't know, but we're going to figure out over the next months and years. So I know that for Rayval, there's something written up in the medication guide about potential for medication overuse headache. Is that the same for all of the new medications that are coming out as abortives, or is there no indication for the Gepants of that?
Yeah, so we don't have an indication that Gepants cause medication overuse. Studies done with rimegepant in which it was used every other day with the option of taking an additional rimegepant. It was interesting, the study showed patients did not use an additional rimegepant, which would suggest taking rimegepant every other day as a preventive eliminated the need for rescue.
Interesting.
So it is interesting.
Yeah.
But so far, only the Allergan and Biohaven Gepants have data on acute
Right.
treatment. So we don't
really know, right?
Once again, we don't really know.
Right. And rimegepant, is that, well, first of all, do we have any kind of time frame for when we expect that to be available? Because I know that they filed for an expedited review, but we don't have a PDUFA date for them yet, as far as I know. Has it been delayed for some reason, or you don't know, or not able to say?
Yeah, FDA time.
Okay.
Is,
So it could theoretically surprise us as well.
It could. Usually these things leak out beforehand.
Okay.
But everyone's being, you don't want to look like an idiot by saying, it's coming out Thursday and it doesn't.
Right.
At the same time, you don't want to create speculation that something horrible has been discovered and it's going to be delayed. So over the years, pharma has learned to just kind of be quiet about that.
Okay, that makes sense. Okay, totally makes sense. Now, do we know if you can take the GPANs or lasmiditan, Rayvow, at the same time or in the same day as a triptan. So, for example, those people who run out of triptans each month, or the triptan doesn't work for a particular attack, is it safe to then take these other meds, or do we not know?
Again, we don't know because it's very difficult to get head-to-head studies.
Okay.
I don't think there's a theoretical basis to say that there's a risk,
Right.
but there is no data as yet.
Interesting. Okay. And for the GPANs, I know that you said that there's a remarkably low side effect profile for them. They seem to be fairly safe. What are the most common side effects that were seen in the trials?
For the GPANs?
Yes.
So they were really very benign. So urinary tract infection,
Okay.
we don't know it. So that's self-reported.
Right.
We were doing cultures on the urine to see whether they really were. So it might be more appropriate to say, urinary tract issues, irritation,
Okay.
some lightheadedness. Really quite nausea was there. They're really quite benign so far.
Okay. So that sounds good.
It does.
It's definitely hopeful. Are there any contraindications for any of the three abortive medications? So Rayvow, ubrogepant, and rimegepant. Is there anything that you would say you would have a patient who has this condition that you personally as a doctor would be concerned or cautious?
So I would not combine the DITANs and the CGRP antagonists in one group.
Okay.
All those two entities have in common is that they're both not out yet.
Right.
The DITAN is a serotonin agent that works at a different, there's about 14 subtypes of receptor for serotonin. The DITAN, lasmiditan, works at the 1F receptor.
Okay.
The triptans all work at the 1B and 1D receptor. So the lasmiditan, its claim to fame is that it doesn't work at the blood receptor, so it's not.
Right. No
blood vessel.
vasoconstriction,
There's
right?
no vasoconstriction.
Okay.
There's really no signal so far with issues with the antagonist.
Okay.
But it's still early.
It's still early, right? Yes. I did read.
Switching to my glass half empty. Right.
You can't do that on this interview.
Okay.
You got to stay glass half full. But
Okay.
that's pretty good. And then let's kind of move away from the contraindications and the side effects, which is kind of the negative side that people often tend to worry about. And let's talk about the efficacy. So, what are we looking at? Let's start with Rayvow, with lasmiditan. What does the efficacy look like from the trials?
It's roughly comparable to the triptans.
Okay. Okay, so that's pretty good.
Yes.
Right. And we don't know, obviously, if someone is not successful on a triptan, whether they will be on this because it has a different mechanism, basically.
Slightly different mechanism. We just don't have data. Those head-to-head studies,
Right.
require collaboration between competing pharmaceutical companies.
Right, which is hard to do.
It's actually not hard to do. It's hard to get the companies to agree to do.
Okay, right, exactly. It's not, from a scientific perspective, it's
Right.
not hard.
Head-to-head studies would be ideal.
Right.
If the FDA required those,
It would happen.
it would have to happen. I mean, them's is the rules. But it would make lives for patients much better, obviously.
Okay, that makes a lot of sense. And then for the GPANs, what is the efficacy profile of those?
So the GPANs appear to have possibly a slightly better efficacy. But none of these, I think the trouble with efficacy, let's use Botox as an example.
Sure.
There were what we call super responders to Botox. It was a long time ago, people don't remember it, but about 7 or 8% of people who took wild Botox simply had no more headaches.
Interesting.
Right? And then for roughly a quarter of them, Botox just doesn't work at all.
Right.
When you average all of the people who were in those trials, there was a decrease on average of about 2 headache days a month over a placebo.
Right.
So that means if you have 4 headache days a month and you reduce it by 2, that's a 50% response.
Which is pretty good.
Which is pretty good. And some companies are not above using that kind of ploy.
Right.
If you have 30 headache days a month,
Yeah.
basically every day, and you reduce it by 2,
It's really not much.
not much.
No, you can go
Right.
shopping one day, maybe.
Exactly.
That's about it.
Exactly.
Yeah.
So I think it's a little misleading when you look at something. I mean, if I answered your question in the simplest way, it's about the preventives are about as good, I'm talking about the monoclonals,
Right.
are about as good as Botox.
Okay.
Now they work by different mechanisms, so it may be that there's an additive or even synergistic effect. We don't know, because again,
Right.
no head-to-heads. And when you average the improvement with the ditans,
Right.
see about the same thing. It's about
Okay.
as good as the triptans. But I think for an individual, and that's really, who we're talking about. We're not talking about scientific studies.
Right.
For a given individual, it can be an absolute home run,
Right.
or it can be another fail. And you don't know until you try.
Right. And presumably you may have to try more than once as
Sure.
well. This doesn't necessarily mean it's going to happen.
The other
the
thing
first
I
time.
would add, and must add, is that medication should only be part of your treatment strategy.
Absolutely.
If you don't do the hard stuff, the lifestyle changes,
Right.
it's less likely to have success.
Right.
The patients who do the best are the ones who take the sleep, and the eating schedule, and
Absolutely.
the exercise very seriously,
Right.
in addition to the medications.
Right. Absolutely. And also some of the alternative options like biofeedback or
Exactly.
acupuncture, those
Exactly.
ones where we have at least some evidence that they may help some
Right.
people. Right.
And nutraceuticals,
Right.
the B2 and magnesium.
Absolutely.
Yeah, so I think it's really unlikely. I mean, if you think about why we have pain, without pain we die
Right.
as a species. That's what tells the children to take their hand out of the fire, right? It doesn't make sense that you should be able to block pain. It's a really bad idea. I mean, that's why we haven't found the magic gene. It's going to be polygenic because there has to be all sorts of redundancy to make sure we know when the environment, whether it's the internal environment or the external environment, is not in sync with what's best for the body. So you're never, it's not, I won't say never, but it's really unlikely that you're going to find the gene to modify or the drug that replaces something that's missing in your system.
Right.
Migraine is a problem with how we interpret sensory input.
Right.
And the only way you're going to manage that is approaching it from
Multiple
many different
angles.
ways as you can.
Right,
Exactly.
no, that makes a lot of sense. So shifting slightly, I know that we have a lot of people in the Hope for Migraine group, and I'm sure there's a lot of people on migraine.com as well, who take narcotics. And we know that narcotics are not recommended for migraine treatment, but there are some people who are not able to take DHE, are not able to take triptans. This may be their only option. And there has been some concern that the taking of narcotics may, in some people, reduce the chance of new medications working. Is that something that you have seen? Is that a concern for these new medications as well? And this, obviously there's no quick and easy answer to that, right? But, just give us your thoughts on that, if
Sure.
you would.
Sure. So opioids and barbiturates, and by barbiturates I'm talking about butalbital-containing drugs like Fiorset, Fiorinol.
Right.
And opioids include things like Ultraset, Tramadol,
Right.
and as well as more common opioids,
Right.
the Darvon, Darvocet, and all that stuff. There is very clear evidence that these create a situation called medication overuse headache, what we used to call rebound headache.
Right.
And basically, what happens when you take these medications is your brain very quickly assumes that it's part of the normal chemistry. Excuse me. And as with changes in estrogen level or changes in sunlight, when that chemistry is disrupted, your brain says there's something wrong.
Right.
And the way it says it is with pain. You have an opioid or barbiturate that's got a relatively short half-life that your brain now thinks is part of the normal chemistry.
Right.
Suddenly it's gone. Your brain says there's something wrong. You get the headache back. So at the highest level, they're a bad idea. I'm not going to say they don't cover the pain, but if you break your arm and you take enough opioid, your arm won't hurt, but it'll still be broken.
Right.
And your brain will figure out ways of making that clear to you. So while I won't trivialize the need for better treatment, I mean, that's what we're talking about today, opioids and barbiturates are bad news.
Right.
And everyone should be doing everything they possibly can to avoid them.
Right.
We just had a discussion this morning as to whether it was okay to say in our guidelines opioids are contraindicated, should never be used, or should
Interesting.
should not be first line,
Right.
or, you know, there are exceptions
Right.
that kind of open that door. Because, you know, it's a quick, easy way to get somebody out of an emergency room.
Absolutely. Yes.
But I haven't prescribed an opioid. And we see the most difficult, challenging patients. Excuse me. Difficult and challenging cases.
I appreciate you.
I really have
that.
to watch my microaggressions, I know. But we see really, really complicated patients.
Right.
And I haven't written an opioid prescription in probably 20 years.
Interesting. Okay. And I think it's pretty safe to say, I think, that for anybody who is trying one of these new medications, if they are taking narcotics for whatever reason, and no judgment at all on that, I have to take them sometimes because I can't take triptans and DHE. So I'm just going to be really upfront about that. But I also am very, very concerned about the fact that it may inhibit new medications working. So I think coming to that point where you say, okay, I'm not going to keep pushing through, so I had to take more and more abortive medications. I'm actually going to take time off work if I have to. I'm going to say no to more things for a while so that you get the rest you need, so that you don't have to take so many of them, so that you give the new medications a better chance to work. Would that be a reasonable approach to
I think
take?
everybody, you know, has their own strategy.
Right.
You know, if you have your appendix removed, you know, odds are you're going to take some opioids for a few days.
Right.
You know, will that, you know, destroy any chance you ever have of feeling healthy again? Absolutely not. But I think, as I said earlier, you've got to go into these things with your eyes open. You have to understand. I can give you a personal example. For my 50th birthday, my wife got us tickets to go see Eric Clapton, who I absolutely love.
No judgment there.
No judgment. No judge, I don't care. Eric Clapton, unplugged, front row.
Wow.
Pretty much a guaranteed migraine.
I was going to say, I wouldn't dare
You
do
got
that.
the
You're
lights,
brave.
you know. On the other hand, the chance to see Eric Clapton live,
Right.
unplugged, I couldn't pass it up.
Right.
So, you know, I pre-medicated, I got my shades, you know, my sunglasses,
Right.
you know, made sure I had a good night's sleep under my belt. You know, I did all the things I was supposed to. Went amazing concert, did get a migraine, totally worth it.
Interesting.
You make your choices.
Right,
You
you
know,
count
you
the
don't
costs
want,
sometimes.
exactly, you don't want migraine to, you know, destroy your life. There has to be a quality to it. The important thing is to have enough information to make those judgments,
Right.
to make those calls.
Absolutely. Absolutely. And that's a really interesting point. I get asked by a lot of people, what is it like for me traveling as a migraine patient advocate, and how am I able to do it? And I make that choice knowing that it's going to make me sicker physically, but emotionally it builds me up. It makes me stronger, just getting that information.
Mm-hmm.
So I make a choice to do that, but I also make a choice to build in recovery time afterwards. So it's just wise,
Yes.
informed choices, right?
Exactly. That's exactly
Yeah,
what
that's
it
very
is.
good. I do have a quick question from someone, and we're going to get to questions with people in a couple of minutes, but I wanted to just follow up on something that I saw. So a few people thought that they heard you say that Aimovig can cause stroke. So yes, exactly.
No.
and I know you didn't say that, so if you could just just elaborate on that.
Good Lord. No,
I just gave you a stroke, right?
You did. I can just picture the calls coming in from Amgen.
Yes,
tonight.
exactly.
No, we have no evidence that Aimovig or any of the monoclonal antibodies cause stroke.
Right.
What I said, or perhaps what I meant to say, is that we have no data on what would happen to someone on Aimovig who then had a stroke because they didn't pick their parents correctly, or whatever reason they have a stroke. We have nothing. We have nothing to indicate what the implications of that might be. For example, I have a patient who has hemiplegic migraine, which is a rare form of migraine, who has found on a monoclonal antibody he has fewer attacks, but the attacks seem to last longer. So he's weak on one side for a longer period of time.
Right.
That's an anecdote, right? If we find that every patient on with hemiplegic migraine has this as an action, that's different than me saying I have one patient. So until we have, hundreds of thousands of patients who are on monoclonal antibodies and have strokes, we can't know whether there's any implication. So please This is complicated stuff. Don't look for simple, I should or I shouldn't kind of answers, because there really aren't any.
Right. It would be nice if there were, but it's just so much more complex than that.
Yeah.
So I have a couple of questions from folks. We're not going to be able to get to all of your questions, but as long as Dr. Cowan is okay with that, I'm going to send you some of the questions afterwards, and
Sure.
then I can follow up with a written transcript for people. So just because we didn't get to your question.
As long as there's not thousands of them.
Yes, as long as there's not thousands of you. Definitely not. Just don't want you to feel like we're not hearing you, because we are. But this is such a huge time for migraine treatment that trying to get through all the questions is really impossible. So we're just doing the best that we can. So please bear with us and have patience with us. So one of the hot questions is, can you be pregnant and taking these new medications, any of them? Or presumably, are there any studies done with people who are pregnant or nursing at this point in time?
No studies.
Okay.
But all of the companies that are producing these monoclonal antibodies and ditans and everything will keep registries.
Okay.
So there have been pregnancies in the studies. There has been no signal from them. But again, that's still not numbers
Right.
enough for the FDA to say this is safe in pregnancy.
It's not evidence at this point in time.
Correct.
Okay. Do we know, here's another question, do we have any evidence that any of the new abortives would be helpful in, so I'm going to actually read this since I don't make a mistake, idiopathic intracranial hypertension or new daily persistent headache?
Again, the short answer is no. Was that idiopathic intracranial hypotension?
It says hypertension.
IIH. Okay.
Yes.
So no, we don't have data on that, but you're kind of moving into territory where we're looking at what we call secondary headaches due to something else. Migraine, tension type headache, cluster, they're all primary headaches. Right. Secondary headaches, for example, many patients with IIH have problems with resorption of spinal fluid. The way to fix that is to correct the production resorption ratio.
Right.
Many patients with new daily persistent headache had some kind of precipitating event. It could have been an assault, could have been a viral illness that immediately preceded the onset of daily headache.
Right.
You need to look at what that event was. Was it a closed head trauma? Was it an emotional, upheaval?
Right.
And then you want to address the underlying cause. Right. So in the same way that somebody with meningitis or subarachnoid hemorrhage will have improvement in their headache with a triptan, you don't want to fall into the trap of having somebody come in who just had a ruptured aneurysm,
right.
Give them a triptan, say, oh, your headache's better? See you in 2 weeks.
Interesting, yeah. Yeah. So very close to that would be people with cluster. Have there been any people with cluster in the trials, or are cluster trials expected with these new abortive medications?
They will look at that. That data hasn't been released. They will look at it. One of the monoclonals, the Lilly product, does have an indication for cluster.
Right, Emgality.
Yes.
Right.
Right. At Stanford, we're not allowed to use trade names, so I just get out of the, I get out of the habit.
That's okay.
But yes, it has an indication for cluster.
Okay.
So part of it is just, cluster, while it's a very severe headache, it's so much rarer than migraine. For pharma, it's business. And
right.
If they can come up with a drug that helps 37 million people, they're going to pick that over drug.
They're going to do that.
Million.
Right. That makes sense.
But that will come.
It will come eventually, right? So another question that we got was for people who are heart patients, have some kind of cardiovascular disease. So I know that with Rayvow that it is not supposed to cause vasoconstriction. And does that mean that it is likely to be safe for people who have heart conditions, and for the GPADs also, there's no contraindication for them at this point in time?
Yes. Okay,
so that's a nice quick answer. Because we don't want to make it more complicated than that, because right. We don't know any more than that right now. Right. But at this point in time, it's not a flat-out contraindication.
Right.
That's basically it. Okay, so I'm looking at some more questions. We have about another 5 minutes to answer questions. So if there's a couple more people out there who want to ask questions specifically about the new medications. So I know that there's obviously a lot more to migraine than the new medications, but this is what we're dealing with in this particular topic. So let us know if there's any hot, burning questions that we haven't already answered. So I'm seeing a question, will these be available in Australia? We don't necessarily have any answer for that right now.
Can't tell you, mate.
Can't tell. Okay. And the next question would be, do we have any indication on pricing for them? The big mega question, right?
Well, the pricing and the payer approval are always the big issues.
Right.
And, we know that the MABs, monoclonal antibodies, came out at roughly the same price as Botox.
Right.
Not a coincidence. I would anticipate that the Japans will probably follow the same suit. There's certainly going to be payer issues for the acute treatment,
Right.
since there are now generic triptans. So, the drug companies will figure out a way to at least get you started so that you can make the argument that there's reason to take it.
Right.
So they'll all probably be approved for subpopulations more easily than for general indications.
That makes sense. And I think ISA is working on their report right now. So
Exactly.
if you have interest in that, then just do a search for ISA, and they have a draft report. In fact, they have an open comment period right now, and we're going to be promoting that in the different chat member groups, just letting you know how you can make comment to ISA while they're getting ready for their report for these medications.
That's ICER.
Yeah. And okay, I'm just looking to see if, okay, so we have another subgroup that's really important. So that'd be people who are over 65, which are generally excluded from the trials. Are there more concerns for someone who's over 65 taking one of the Gepants or Rayvow or even eptinazumab, or is it, again, we just really don't know?
I'm not, and less so as I get older, a big fan of using chronological age for making that determination.
Okay.
I've seen 80-year-olds, 90-year-olds that I would have no hesitation. I've seen 50-year-olds that I wouldn't let anywhere near these drugs.
Interesting. Okay. Then let's go to the other end of the age spectrum. Are there any trials that you're aware of that are starting for minors with these new meds? Okay.
So now the FDA actually requires that studies be done in children.
Okay.
So those will follow.
Okay, and I think for one of the injectables, there's been an ongoing trial for children. For I don't know if it's for Aimovig or one of the others.
It's for all three.
It's for all three of them.
All three. I mean, it's been mandated by the FDA.
Okay. All right. So we're just waiting to get the early
Sure.
results from that at this point in time. Okay, so we're going to bring this to a close, but we have like 2 minutes left. Is there anything that I've missed out that you think is really important that needs to be said?
I just want to reiterate, Aimovig does not cause stroke. I'm just picturing the calls coming in from Amgen.
Yes, and on my group, we're going to blow up my group and migraine.com with those questions. So
No, I think that, with new classes of drugs, you just have to be mindful that there are things we don't know. And it becomes a risk-benefit decision, and that decision should be yours. It should not be your doctor's. Your doctor's job is to give you enough information to make that decision for yourself. There's a lot of other really exciting things. There's some old wine in new bottles coming along, different delivery systems for existing drugs that are really exciting. There are some devices that are coming out which have minimal or no side effects and pretty strong data supporting them. So there's a lot to come. Migraine is finally getting some attention, and it's a very exciting time to both be a physician taking care of patients with migraines, and it's a very hopeful time for people with migraine because we're finally making some headway.
Absolutely. I think it really is exciting. I know for myself, I've had migraines since early childhood. So it's the first time I've ever actually been excited about the future and the potential. I know that for some of you out there, it's really, really hard to think about waiting even another month or another 6 months or another 2 years for something new to come out. But in the world of a disease like migraine, things really are starting to change. And so now is the time to have hope. Now is the time to make sure that you educate yourself, that, to see your relationship with your doctor really as a partnership. So be responsible and to find out what's out there and to track what happens with your migraine attacks so that you can give your doctor adequate information to help him treat you more effectively, I think would be really important things to say. So we're going to bring this to a close. Thank you so much, Dr. Cowan, for being with us today. It's been a total pleasure.
Good.
And maybe we'll be able to have you back sometime in the future, but Thank you so
It'd
much.
be my pleasure. Thanks for having me.
All right. Thank you. Take care. And goodbye, everybody. Thank you for joining us today.